welcome to the EMS On AIR Podcast. The mission of this podcast is to keep healthcare providers safe, informed, and prepared. Today is August 17, 2021. This episode was recorded July 14, 2021. I'm Jeff Lassers, and I'll be your host. Even though we're located in Southeast Michigan and we mention our home state a lot, today's content applies to EMS on the national and even the global scale. In our last episode, we discussed stroke systems of care, EMS, and the urban environment with Dr. Christopher Richards, an emergency medicine and EMS physician in the Division of EMS in the Department of Emergency Medicine at the University of Cincinnati. Today, we welcome Dr. Christian Martin-Gill, who is here to provide us with his perspective regarding the development of stroke systems of care in the suburban environment. Doc is an ED physician with a deep background in a variety of EMS systems. Specifically, Dr. Martin-Gill serves as Chief of the Division of EMS, the Fellowship EMS Director, and is an Associate Professor of Emergency Medicine at the University of Pittsburgh School of Medicine. He has been a nationally registered paramedic for over 20 years, and he is also a certified flight paramedic. In addition to his clinical role as an emergency physician at UPMC Mercy Hospital, a comprehensive stroke center located in Pittsburgh, he serves as Associate Medical Director for STAT MedEvac and UPMC Prehospital Care. Most recently, Doc was a co-author of the 2021 recommendations for regional stroke destination plans in rural, suburban, and urban communities from the Prehospital Stroke System of Care Consensus Conference, which is the focus of today's episode. This landmark consensus provides local and regional EMS agencies and stroke advisory committees with guiding principles and recommendations for how to integrate the elements of a stroke system of care in three key regional settings: urban, suburban, and rural. It also takes into account differences in resources, hospital certifications, geography, and population density. Additionally, it seeks to inform or update EMS about new models and systems of acute ischemic stroke care, especially mechanical thrombectomy for large vessel occlusion stroke, and how they affect their stroke systems of care. You can find a link to the 2021 recommendations for regional stroke and destination plans in rural, suburban, and urban communities in the episode description. To maximize the power of the recommendations, the American Heart Association, American Stroke Association produced a very cool and very useful website full of resources and information directly related to helping EMS develop and or fortify their stroke systems of care. I highly recommend you visit stroke.org/stroke transport plans and use it to consider evolving the stroke system of care in your community. This is a fantastic resource for anyone with any interest or stake in their stroke system of care. This is an especially helpful website if your EMS system is considering implementing a stroke severity scale, or if you're considering hospital bypass criteria for patients with LVO stroke. During this episode, Dr. Martin-Gill helps us appreciate what is at stake for stroke patients. From there, we get into the focus of the discussion, which is the nuances, advantages, and disadvantages of the suburban environment regarding EMS and stroke. Finally, Doc provides his recommendations regarding how EMS systems should use the contents of the consensus and the stroke.org/stroke transport plans website resources to improve their stroke systems of care and strengthen their stroke chain of survival. As always, you can find our guest's email address in the episode description. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to our podcast and leave us a rating and a review. It really helps us to grow this podcast. Thank you for listening to the EMS On Air podcast. Enjoy the episode. Good morning, Dr. Christian Martin-Gill. How are you, sir?
I'm doing great. Appreciate you having me on.
Well, we appreciate you making time for us. Why don't you start out by telling our audience who you are, what you do, and where you do it?
I'm an emergency physician, associate professor of emergency medicine in Pittsburgh. I work at a comprehensive stroke center near downtown Pittsburgh called UPMC Mercy Hospital. And I have the privilege of being the chief of the Division of EMS at UPMC, where I help, along with a variety of colleagues, provide EMS medical direction to a wide variety of EMS agencies, both ground and air critical care transport.
How many agencies do you oversee or help the oversee of?
So we have a large critical care transport service called MedEvac that has 18 base sites across 5 states. We oversee that right here from Pittsburgh, as well as helping about 100 different ALS and BLS, including first responder agencies in Western Pennsylvania, which is very exciting, particularly with about 40 of those being ALS services that they take very active care of stroke patients.
Well, that's a lot of calls to oversee and assure for quality improvement, right? And then, not a majority of those calls are stroke patients. It's really not a ton of them. So to kind of tee up what we're talking about here today, can you help us appreciate what is at stake for stroke patients?
When I think about taking care of stroke patients, I really think about 2015 being a landmark year in the way that our thought process changed, particularly in the pre-hospital environment for how we take care of stroke patients and really what's at stake for them. Before that year, we thought about stroke care as trying to identify those that we may be able to give thrombolytics to. And papers at the time really were showing that only in about 4% of patients were we actually giving that treatment to try to substantially improve the outcome of patients. And certainly that's a pretty small number of patients. You already talk about how stroke is a proportion of all of the types of patients we see in the pre-hospital arena. And then if you take that subset and you think about only maybe 4% of those actually getting the main intervention that was available at the time, you really think about a substantial portion of stroke patients not having a lot that we could do immediately, and most of their care being related to rehab. And what it really matters for the stroke patient is when they have a substantial deficit caused by a large vessel occlusion. And for those patients, they may have hemiplegia, they may have an immediate loss of the ability to take care of themselves, do activities of daily living, be gainfully employed, all of the things that really change their lives. And what happened in 2015 was the publication of multiple randomized controlled trials that showed that endovascular procedures could substantially change the outcome for those patients. And so in the pre-hospital arena, we really became much more integrated in trying to identify which of those patients we could help and trying to get them to the right hospital so that we could change their outcomes substantially if they were eligible for and ultimately receive one of these endovascular procedures. So a lot has been at stake all of this time, but especially since those procedures have been available. And now that we know the benefit to those outcomes, we know that we can identify those patients better in the pre-hospital arena and get them to the right center while ensuring that those patients that are eligible for thrombolysis that may get those at a closer hospital can get that. And identifying patients that may have more limited deficits where care at their local community hospital, where their regular doctor is and where all the records are, would still be the plan of care. So the outcome of patients is really substantially impacted by what we provide for them, and pre-hospital care has become an even more integral role to maximizing that outcome for patients.
Thank you for that very good, comprehensive explanation. That was very well stated. Now you're talking about the world of EMS, and then we can stratify that world of EMS down into the environments of which it serves. We've spoken to a number of doctors about this recently. Specifically, you operate in the suburban environment. Can you talk about the nuances of the suburban environment regarding EMS and stroke care?
So it turns out that, as I described, here at UPMC, we help a number of partner EMS agencies across a large swath of geography, and that includes both the urban environment of Pittsburgh, suburban environment around it, in rural areas of Western Pennsylvania. And that environment really is different because the availability of hospitals of different types of different locations with different transport times really makes it challenging to at times make decisions about where patients should go and how quickly we can get them to certain definitive care. So it's been very much on our mind about how we can optimize the care that we deliver to patients in all of those environments. And it was a pleasure to be able to participate with this team where the group was trying to identify how can we provide guidance based on the type of area that somebody is in or that EMS agency is operating within, and recognize that there are going to be distinct features of an urban environment or suburban environment or a rural area that would lead to different guidance of how we may take care of those patients. And as you mentioned, I had the opportunity to work most directly with developing the guidance for a suburban environment. which is rather unique in particular because of the differences in access to different types of hospitals and different capabilities.
Like every environment or set of conditions, we are presented with challenges as well as advantages for those environments. Can you talk about the differences and advantages and challenges within that suburban environment for EMS when it comes to stroke patients?
Yeah, I definitely like to think about the positives as best as possible. And there are quite a number of advantages that we have in suburban environments when we think about the stroke care we can deliver to our patients. Specifically, it's more likely in a suburban environment that we're going to have hospitals near us that have capabilities to deliver endovascular care. So we're talking about comprehensive stroke centers or thrombectomy capable stroke centers as defined by the American Heart Association criteria and definitions. And we're going to have greater access to those types of hospitals than most folks would have in a rural environment. And we may actually have, at times, even better access to those centers at urban sites, because sometimes in urban sites, those larger hospitals have even moved to the suburban communities because of space and location. And so it may be that actually in a suburban setting, we have the best access to those hospitals because they happen to be near us. And it is more likely that the hospitals that we are located near have higher volumes of patient care than rural areas. And it's been demonstrated across different acute conditions that higher volumes of patients seen at specific hospitals are associated with better outcomes for patients. This is true for stroke patients. It's been demonstrated in trauma care. It's been demonstrated in myocardial infarction or STEMI care. And so we know that if we're near hospitals that not only have the best capabilities, but also see a substantial number of these patients, we're well positioned to be able to take them to that right place and get them the care that we want. And in fact, because suburban areas are typically, or by definition, positioned around an urban area, then we know that we're going to have reasonable access to both the capabilities within our suburban environment and get into that urban setting where there may have the largest or most comprehensive type site. And so we're going to have options. We're going to be able to tailor our protocols depending on what's going on with an individual patient. And we're going to be able to tailor the destination and the care that we deliver for the right patient at the right time, the right location.
Yeah, it seems to me that when we are in these suburban environments is the most critical thinking that needs to occur because your options are so different compared to what you're going to find in urban or rural. When you're in suburban, you're typically attached or affixed to a urban environment, but how far? Suburban environments sprawl out for quite some way, which may lead into the next urban environment or up against a rural environment. It's almost like the most critical thinking and planning really needs to be taken at the suburban environment because it's way less cut and dry than its cousins, urban and rural.
Yeah, and in fact, that's almost a catch-22 because some of the items that make working in a suburban environment a great advantage by having access to a variety of different types of hospitals actually can be one of the challenges about how we operationalize protocols and the care on the ground by that EMS practitioner that's in the field and who has to ultimately make decisions about where to take that patient and the care that we're delivering. Hopefully, and often having conversations with a medical direction, with a physician that can help best direct the care of that patient. But what we ultimately have to deal with is that we may have to make a decision that we have a comprehensive or thrombectomy capable stroke center with a certain amount of distance, or maybe even multiple options for those different types of hospitals versus being able to go to primary stroke centers or other non-stroke centers. And so it creates a challenge having the availability of decisions or options available to make those decisions. Whereas in an urban environment, it may be very simple to say, well, let's take everybody to the highest stroke center because there's so many of them nearby. It isn't really a challenge for us to get to those hospitals. On a rural setting, it may be more cut and dry to say, clearly a primary stroke center is closest to me. Clearly, a comprehensive stroke center is going to be a farther transport, maybe even a helicopter ride away from me. And so we can more clearly delineate the types of patients that we would take to one place or the other. So in a suburban setting, we're really going to have to do some thinking and make it as applicable to what's going on with that patient at that time and how long their symptoms have been going on to make a decision about destination for those patients. Not only that, but in suburban settings, it's more common that we have a greater mix of types of EMS agencies. across the country, urban settings are more likely to have a paid, possibly municipal or maybe a private EMS agency that provides care for those patients, where it's a high volume service in a very structured, large agency. In a rural setting, it's much more likely that we have a volunteer, smaller agency covering a large swath of territory. And so there are commonalities when you look at those types of settings. In a suburban setting, we may have a mix of all the different types of agencies you can imagine, whether it's municipal or private or hospital-based, whether it's paid or volunteer, and all of the different permutations that we have of types of EMS agencies and EMS practitioners. What that means is that when we try to implement education, implement protocols in those environments, or we try to figure out how to best care for those patients, we really have a heterogeneous group of EMS practitioners, and we may have greater challenges about how we're able to reach out to individuals to teach them the best way to take care of patients, to implement a new protocol, and to implement things like a stroke severity score, where we may have to better identify the type of stroke that somebody's having, and how all of that integrates in the care that we're providing for patients.
Well, Doc, you certainly conveyed that, even since 2015, we've had this technology proven to help stroke patients. And for years, we've really relied on our primary stroke centers as those hubs for stroke care. But as the technology increases, we've also seen an expansion into comprehensive stroke centers and then into thrombectomy capable stroke centers. But that doesn't mean that primary stroke centers don't exist anymore. And in many systems, you have a smattering of primary and now thrombectomy capable, and then all the way up into comprehensive. What is the role of the primary stroke center in this new stroke world for EMS providers?
Yeah, I think that that's a particularly important question for suburban environments, because, if you're sitting in a suburban environment, you look around at the hospitals around you, it's very common that you have quite a number of different primary stroke centers in that community, or depending on the number of hospitals that you have. And you may have one or two comprehensive or thrombectomy capable stroke centers. And so trying to make decisions about not just sending all stroke patients to one hospital, but to send the right stroke patient to the right hospital becomes a really critical decision in this environment. And we want to continue to maximize the care provided and the ability of primary stroke centers to care for stroke patients when the type of care that we anticipate that patient's going to need is appropriate for that location. So it's just as important for us to be able to identify individuals that have a large vessel occlusion, that we can get them that endovascular treatment, as it is to ensure that those that, for example, are eligible for thrombolysis get to a close hospital that can deliver it, like a primary stroke center. And where we think that it is highly unlikely that somebody has a large vessel occlusion, that we get them to a hospital that is near them, where they likely already receive care for all of their other conditions, where their physician may already be, where their family can attend to them more closely, and where we maximize the role of those primary stroke centers in our communities, where we can take care of those right patients.
Yeah, that's certainly been one of the biggest challenges in the education realm in EMS. When I talk to EMS providers and they say, well, why wouldn't I just take them to this higher level of care? And I tell them it's not technically the right hospital for them. And you certainly get into the same challenge each time. And it's almost a scripted discussion at that point to lead them into the fact that there is still a very strong case for the use of thrombolytics for specific patients. So when we have these EMS agencies that are learning all of the details and nuances of a stroke severity scale that they have installed into their system, they'll get it. But if you just have a provider that has only been given the tools to do a Cincinnati and then rule out stroke, it's a little bit harder discussion to have. So for those providers that haven't been given all of the knowledge and nuances to really delineate what type of stroke patient needs to go to what type of stroke center, can you highlight some of the challenges that present themselves if you just decide to take all your stroke patients or potential stroke patients to the highest level of care in your area? What happens to that hospital?
Yeah, I think a great parallel that a lot of folks can relate to is thinking about the way that we take care of trauma patients. Now, trauma systems have been in place for over 40 years, and we have become very accustomed to identifying specific criteria that would warrant taking a trauma patient from a scene to a trauma center. And we have very structured guidelines that have been developed that have been to this day managed by the Centers for Disease Control and Prevention that have been adopted across local, regional, and statewide protocols that help us to assess based on this physiology that I'm seeing, based on these mechanistic criteria, based on these other patient factors, this patient should or should not go to a trauma center. And you can relate to understanding that if we took every single trauma patient from a severe motor vehicle collision with multiple injuries to an ankle sprain, when we took all of those patients to a highest level trauma center, they're just going to be overwhelmed and we're not going to use those local hospitals for our base capability. And really what's happened since 2015 in identifying that we need to differentiate patients with large vessel occlusions versus other types of stroke patients, we realized that through our own improved stroke guidelines, through these improved stroke severity scores, we're better able to triage those patients like we have done for decades for trauma, and we can help to differentiate the patients that we need to get to those higher level centers so that we don't overwhelm the highest level stroke centers and we can get the right care for the right patient at the right time.
Now, certainly in the trauma world, we've had, like you said, many years to collect, measure, and evaluate data and its implications on patient outcomes. And that stratification of where we take our patients that suffer traumas, taking them to the right place, certainly impacts them, and we see the data. We all know that since 2015, there's been a lot of updates in the stroke world. That's not a long time to gather data, measure, and evaluate the patient outcomes. So are we at the point right now where we are equating these transport decisions to better patient outcomes? Or are we still in the theoretical process of if we do this, we should see improvements?
We already have, with those randomized control trials and a lot of other research that has been published over the past 6 years, we already have very strong data on outcome benefits for patients that are able to reach these procedures. We also have data on the importance of time to intervention. So, for example, if a patient ends up at a smaller hospital and then ultimately needs to be transferred to a comprehensive stroke center or a thrombectomy-capable stroke center, we know that delays in transfer and delays in getting to that ultimate therapy are directly associated with the outcomes for those patients. And being able to get them to that definitive care as quickly as possible, preferably directly from the scene, really has an outcome benefit for patients. And obviously, all of that literature continues to grow. We continue to have new studies and new assessments of data to figure out just which patients most benefit from that and how best to identify the ones that need to be sent directly from the scene of those sites. But we know that if we can identify those and we can get them to that care in the most timely way possible, it is directly associated with those improved outcomes. What we need more literature on is how best to identify those patients. There are currently a wide variety of stroke severity scores, and a number of folks have looked at individual stroke scores to figure out which one is best. And, I would tell you that most of the literature that has been published suggests that several of the stroke severity scores that are out there are fairly similar in how good they are at identifying large vessel occlusions. And so for folks on the ground, what needs to matter the most is ensuring that you're using one of them, that you're not limited to a stroke scale that is just answering the question, yes, no, it is likely or not likely that somebody's having a stroke, but that you've worked with your EMS medical director, you've worked with your agency leadership to implement a stroke severity score so that you can figure out not only is it likely that this patient is having a stroke, but it's likely or not likely that they're having a large vessel occlusion. And now we can get going with figuring out how we integrate into a stroke system of care so that we ensure that the right patient is going to the right place at the right time and minimize the time that we get them to that final procedure, which we've tied to outcomes.
Thank you. Now, the biggest challenge in that situation is getting every EMS agency up to speed on the use of a stroke severity scale. And in my opinion, it is not the EMS provider that is the rate limiting step of implementation, but rather the limited resources that would allow medical directors and EMS systems to identify the best one for them, plan the training. I mean, there's so many logistics involved into upping this situation that it's almost so daunting that some smaller departments or systems may be relying on bigger systems to, quote, figure it out and then have it implemented nationally. So I get it. There's plenty of systems out there that have the biggest hearts in the world and the smallest pockets. And then there's the opposite of that. So it's very tough. It's a balance. So what do you say to the general EMS community that doesn't have a stroke severity scale implemented? What do you say to their EMS medical directors to help them really motivate, guys, we got to get this moving?
Yeah, you first need to partner with those EMS medical directors and ensure that you're on the same page in terms of the value and importance of implementing this. But it really comes down to how protocols are created for a specific agency. We've got EMS protocols that are based on local, countywide, regional, or statewide guidance. In Pennsylvania, for example, we use BLS and ALS protocols that are created at the statewide level. And so conversations that would lead to protocol changes are done through our state or Commonwealth EMS medical director, Dr. Doug Kupas, and a panel and a stakeholder group that helps to provide guidance to the Bureau of EMS at the Commonwealth level to change the protocols that we use. And so to try to implement things, the way that we can help to engage that is by doing quality improvement or pilot projects that help to demonstrate what may be of most help to our communities, and then help to provide data and provide information that then guides and ultimately leads to protocol changes. And that's exactly what we were able to do in Pennsylvania. So at UPMC, with the EMS agencies that we partner with, we were able to implement a region-wide protocol for the assessment of stroke patients through a modified version of their RACE score, which identified the stroke severity, and then triaged them to the right hospital, whether it was a comprehensive or thrombectomy-capable site or a local primary stroke center. And we're able to demonstrate over the course of 1,000 patients that the way that we had implemented that protocol regionally was working out. We were identifying patients that ultimately received these endovascular procedures. And then with that data and with that information, inform our statewide partners so that we could make modifications to the statewide protocol. Now, how that happens is going to be different for an agency that is based on local protocols or countywide or region-wide protocols. And it may actually be simply up to the EMS medical director to make a decision to change the protocol that only impacts that agency. And so it's important to try to learn from those that have changed around you, to try to look at what resources are available. We selected our stroke scale because we did a retrospective analysis of all of the stroke severity scores and which ones seem to work best in our environment. And the modifications that we made to the RACE score were in a way that helped us most easily educate our personnel in the use of a stroke severity score and figuring out that it worked well to identify stroke patients. So some local modifications, some ways that we can minimize the workload and best optimize the way that we implement it in our environment are going to be key parts of the conversation to decide exactly how to do it in your locality. But right now in 2021, we have a lot of examples across the country for folks that have implemented the Cincinnati Stroke Severity Score, the Los Angeles Motor Score, and a variety of other scores that are used in other locations.
FastED, just dropping our own in there just to make sure.
The FastED score, and a variety of other examples that individuals can draw from and gain from their experience so that hopefully we're not now at a point where it is too challenging to implement this, and everybody should really incorporate some version of this in their own locality.
Yeah, the understanding and availability of resources to implement any of the 24 stroke severity scales that are, quote, validated and being used in the EMS field, you have plenty of options. And my favorite part of the stroke severity scales is they're not made out of stone. You can modify them however it fits your system. And my favorite story so far has been out of North Carolina with our new friends, John Studnick and Patricia over there at Medic. And what they did is they took FastED and they said, well, this is great, but FastED traditionally is a 4 or greater. But they looked at all of their data and recognized if we change that score to, I think they went with a 5 or a 6, it actually improve the patient population within their geographic region. So the point is that we have lots of options of tools that you can use and implement within your system, but don't worry, because if they seem too daunting, you can change them to fit your system. So you're right, is that there's so many examples. There's really no more excuse because it seems to be a lot of resources out there to implement. The rate limiting step is the availability of systems ability to put this on the radar to implement a stroke system of care that includes this and EMS.
Yeah, and a key part of actually implementing this on the ground is recognizing that the goal is not to find the single best stroke severity score or the single best way to implement the protocol, but to identify that we need to use a stroke severity score, that we need to have specific guidance of which patients we take to different places. And we need to figure out ways to implement those changes to our care if that's already not in place. And making sure that, again, that we partner our EMS medical directors with our EMS personnel on the ground so that all of that stuff is actually happening. That's what matters the most. And that's what's going to change patient outcomes.
Absolutely. Couldn't say that better myself. So, Doc, you and a number of other people, including me, were involved in this consensus paper that we talked about in the intro. And it was developed basically on all the things we talked about today, what EMS systems should be doing. And so the American Heart Association, American Stroke Association put together a consensus on how to help the different environments that the United States EMS systems face. So can you tell us how this consensus paper should be utilized to improve any stroke system of care for EMS?
What I think is particularly unique about this paper and what this stakeholder panel was able to do coming together was provide fairly concrete guidance that wasn't a broad stroke treating everybody the same way, and recognizing that operationally on the ground, there are differences across EMS systems, and that we could tailor some of the guidance that was provided based on the type of region that an EMS agency is located within. And so there are very concrete recommendations for those urban, suburban, and rural settings where somebody who's reading that paper can say, well, my system is the most like this, and what is the specific guidance provided for that type of region? Now, what this white paper is not trying to do is prescribe exactly how a protocol should be defined and exactly how many minutes away a hospital needs to be before a protocol would tell you to take them there. But it does provide very concrete guidance that can be adapted to the details on the ground within a region. So what I would tell somebody is that first off, read the paper. This is good stuff. And be able to identify what your region looks most like and see how your protocol does or does not mesh with the recommendations that are being provided, and how you may be able to tailor the specific action items to ensure that we're both identifying the severity of stroke patients and then getting them to the right locations based on your geography, how far away you are, how long it's been since the onset of symptoms, and other details of that particular case. I think it's also important to partner with the local hospitals or your local EMS medical direction so that you can make real-time decisions. It turns out it's hard to paint with a brush a picture of all stroke patients right from when you're writing a protocol, and that there are individual details about specific patients, not the least of which is where you are physically in that geography at that period of time, and how long it's been since the onset of symptoms that may influence what the ultimate destination should be. And partnering with an EMS medical director or EMS online medical direction would be able to help EMS personnel make those real-time decisions on the ground.
Fantastic. Now, I agree that this paper is worthy of reading, but not everybody is into reading this type of stuff like maybe you and I are. So I thought that was really cool that the American Heart Association, American Stroke Association built this really nice website to really help convey all the infographics and information the paper conveys and all the things that an EMS system or medical directors or hospital systems or even states could use to plan out a stroke system of care. They have created the website called stroke.org/stroke transport plans. Now that'll be in the episode description with a link, but this website is dedicated to taking all of the information from the consensus paper and building it in a way that any EMS provider like you and me who like pictures and consolidated information and good reference information, you can pull it out very, very easily. So If you are an EMS provider who makes decisions in your system, or you're trying to help make decisions on that, I would go to this website and pull the information, plead the case that you should be installing stroke severity scales within your system, as well as measuring and evaluating your stroke encounters to keep improving the stroke system of care in your area.
Yeah, so I'm talking to you, EMS clinician out there, the EMT, the paramedic, the AEMT, the EMR, person that's out there actually taking care of patients on the ground. If you want to find out more and know how to have that conversation with your EMS medical director and the folks around you, grab one of these infographics. That's what you want to grab, and you have a cup of coffee with that person and start seeing, how does our protocol and the care that we deliver mesh up with these recommendations in a very nice, concise way that you can just look at those graphics and those very key recommendations to figure that out. If you instead are that EMS educator who's trying to think about that next con ed that you have about stroke care, and who's trying to figure out how best to help people grapple with all of the words that are within this paper and all of the details that have been looked at and all that discussion that's in there, these infographics can help to put this into context. They can help to flash up for those personnel you're going to be in front of, and can help you really describe some of the key bullet points that we've been discussing here on this podcast and that other folks have done in similar conversations. And finally, if you're that EMS leader out there, you're trying to figure out, whether as an EMS medical director or an agency director, and you're trying to figure out, how can I optimize the care? Or maybe care is optimized, but we want to make sure that we're consistent with what the American Stroke Association, the American Heart Association are recommending out there. Then you grab these graphics, you grab these bullet point recommendations, you compare them with your local protocols and what you're actually using, and you ensure that what you're doing is optimized for your environment based on the description of your EMS system, and make sure that you're providing the highest level of care possible. And if each of us recognize those roles that we might have in our systems, and we engage in a process to continue improving the stroke care for our patients, that's how we're going to maximize and be the best part of the chain of survival.
I love it. Now let's get into chain of survival. Can you describe how EMS can best serve their stroke system of care and strengthen their chain of survival? And for the context here, let's say a stroke system of care is the plan to achieve the best outcome for the entire community, and that chain of survival is that process of the patient encounter, its care, and long-term health.
Yeah, I think a lot of folks think about the chain of survival with the way that we think about taking care of cardiac arrest patients, where the concept of a chain of survival has really become very strong. And when we recognize that there's bystander care, there's the early initiation of CPR and defibrillators, there's the activation of the 911 system, there's the care that is provided in the hospital, and all of that makes a lot of sense to us. I think that rewinding back to the beginning of our conversation, where we identified that in 2015, really the treatment and the concepts around stroke care really changed or were made more aware for us, we realized that pre-hospital care and EMS agencies and clinicians are a very integral part of the chain of survival for stroke patients. Not only are we identifying those patients in the field, but helping to delineate the severity of their stroke and the type of intervention that would be most appropriate for those patients. And we've implemented that for trauma care. We've implemented that to identify patients that need a cath lab activated to help with their heart attack. And now we can implement that type of an assessment, that type of a differential transport to patients having a stroke. And so really, I would say that the EMS assessment on the ground and the decisions that we make about where we're going and the types of heads up we give to the hospital so that we actually can implement those stroke alerts and the care that's going to be delivered in the hospital as early as possible, and we can get all of that on a positive trajectory. That's how we have an integral component in the chain of survival for those patients, so that we minimize the time to specific interventions, whether it's thrombolysis at our closest primary stroke center, or it's an endovascular procedure at a comprehensive or thrombectomy-capable stroke center. And ultimately, we link that patient up to what's going to best change their outcomes, and we lead to good care.
Thank you very much, sir. That really consolidates all of that very well. And I think it motivates our EMS systems to really look into this and question, are we doing the best we can for our stroke patients? And I get it. Stroke patients are not a large majority of our patient population. This is a high-risk, low-frequency event that requires all of us, and I mean the people that go on the calls, the people that receive the 911 call, and the people that receive the patient at the hospital are all on the same page, because that chain is going to lead to the best patient outcomes. And that's really what it's all about. And this is that next evolution in stroke care. Where I came up in EMS, when I was going through my training, the Cincinnati stroke scale was about 10 years old, if not a little less than 10 years old. And that was the maximum of our stroke education and applying stroke assessments. But now I can definitely see over the next few years implementing these new strategies and understanding, number one, systems of care, and then understanding the value of installing these stroke severity scales into EMS agencies to more particularly and accurately identify stroke patients and then get them to the right hospital, becoming the standard of initial education, rather than us having this conversation of how do we even convince systems to start walking down this road.
I know that we're continually exploring how best EMS impacts the care and changes the outcome for patients across all of the types of patients that we see. And sometimes we may feel that we're giving a patient a ride to a hospital and there are not a lot of interventions that are going to change their outcome in the short term, just because we may see more minor complaints and other things. Stroke care, STEMI care, trauma care, these are acute conditions where what we do on the ground can really impact what happens to patients. And really, it's in the past decade and in the past 6 years that we have defined that our interventions, our assessment, our transports, our care in the field for stroke patients really helps us to be an integral part of that system of care and ensuring the best outcomes for those patients.
This is usually where the show ends, but we've added a bit of content that applies to this module from another leading expert on the subject. Dr. Yauk is the Chief of System Research at the Mission Research Institute Mission Health System. He is also an adjunct professor in the Department of Emergency Medicine at the Medical University of South Carolina, as well as an adjunct professor at the Departments of Emergency Medicine and Neurology at the University of North Carolina, Chapel Hill. Dr. Yauk's experience with both neurologic emergencies and emergency medicine, along with his interest in and appreciation for EMS, has made him a bit of an expert in the development of stroke systems of care from the ground up. Most recently, Ed was the primary author of the 2021 Recommendations for Regional Stroke Destination Plans in Rural, Suburban, and Urban Communities from the Prehospital Stroke Systems of Care Consensus Conference. In a moment, you get to hear a few segments from the EMS On Air Podcast Season 2, Episode 33, which is also available for EMS credits. I think you'll find what he has to say adds value and nuance to what Dr. Brandler discussed in today's episode. Enjoy this additional segment. Dr. Yauk, Ed, can you let everybody know who you are, what you do, and where you do it?
Sure. I am an emergency medicine physician by training. I started practicing back when I finished medical school in my residency at the University of Cincinnati in 1993, and was very fortunate to get exposed to stroke at a very young age. Although I wasn't young, as part of my second career, I was still formative. And I met some great people in emergency medicine and neurology who convinced me that stroke was cool, and this was a great place to spend my future. So I was at the University of Cincinnati on faculty for 10 years, and then went to the Medical University of South Carolina for 10 years, and was the division chief and interim chair there, and helped start a statewide stroke program. And 3 years ago, I moved to the mountains of Western North Carolina to become the chief of system research for the Mission Health System. And I've been here for these past 3 years.
Well, it sounds like you got some expertise there, sir.
Well, I am a one-trick pony, and so this is all I do, so I better be good at it. I spend a lot of time with the American Heart Association on various projects involving stroke and also education, and then I work at the various state levels, directing either stroke oversight committees for like South Carolina, or I currently chair the EMS subcommittee on stroke here in the state of North Carolina. So this is, again, my passion and my gig.
I got you there. And you also have some direct contact with EMS out there. You're pretty active in the teaching world too, before pre-pandemic. You're not exactly just sitting there writing papers. You're also a hands-on kind of guy, right?
I try to Boston's EMS training program and work with them, and did a lot of training in the pre-hospital settings for really at both at the state level, trying to create integrated training modules for them, and also working with my more regional ones in stroke, and also doing research in the pre-hospital setting as it relates to stroke.
I wanted to get your opinion on something and help us appreciate what is at stake for stroke patients.
Yeah, I think it can be boiled down to quality of life. We as emergency physicians, our goal is to have everybody survive to admission, and we rarely see what happens to these patients after they leave. And we've seen trauma patients die on our watch, we see STEMIs die on our watch. We really never see what happens to stroke patients, and they don't come in all bloody, they don't come in all screaming. They're very quiet, they sit there, and they kind of get admitted in that same state. But once you start experiencing what happens to them, especially if they aren't reperfused, and the outcomes that they have and the quality of life that they no longer have, and not only the impact on that patient, but also their families and their communities, it really is devastating. And that's not something as an emergency physician I was aware of until I started getting deeper into the field. And so for me, what's at stake is being able to return a person to a good quality of life versus being dependent. And you've probably seen this. I know Steve has probably seen this. When I have gone to a patient's bedside when I'm on call for stroke, and I give them the options of what we might do for them, including TPA, and even after I tell them based on the original NIN study that there was a 6.4% hemorrhage rate, almost universally the patient or their family members, when it's a large stroke, will say, I know my fill in the blank would never want to live this way. So it's not the fear of death that really is terrifying to them. And there was actually a really cool study looking at, your aversion to an outcome. Death was an 8. And a severe cognitive, language, or even motor deficit, people don't want to live in that, quote, vegetative state. It's not a term I like to use, but this is what our people think of. And so they will take opportunities for an improvement in their current state, even if it comes with a risk of a worse state, because what they're currently in is really bad and it's not a tenable existence that they would want for their loved ones based on what they already know about their loved ones. So for me, what's at risk for not doing this right is leaving people in a quality of life state that was potentially preventable.
Help us really define, in your words, what a stroke systems of care is and how it relates to our stroke chain of survival.
So I'll start a little bit more broadly, and I'll just go with what is a system of care, because we didn't invent it for stroke. We've had it for trauma, and we've certainly had it for STEMI care. So a system of care is an organized, coordinated effort in a defined geographic area that delivers the full range of care to all patients. And it's integrated with the local public health system. And so when I say local public health, that can be at the state level, that can be at the county level, that can be within your regional group. It has to engage all the various stakeholders. And what we really want to ensure is just like what we want to do in the hospital, that this system operates cohesively, that there's a seamless transition from each phase of care. So from the 911 experience to EMS, to the hospital transition where they get brought to the emergency department, to the unit, the floor, the next place they go, or they go to another hospital. We want those transitions to occur as seamlessly as possible, as quickly as possible, and we want that team, that system of care that provided that smooth transition to have a process improvement element to this. And so we can go back and continuously improve and identify weaknesses in that system. Sometimes we can't fix it ourselves. Sometimes we have to go out and advocate for more resources. We have to advocate for money for our critical access hospitals. We have to advocate for more EMS. So a system of care, regardless of your disease state, an organized, coordinated effort around a time-dependent emergency that originates in the pre-hospital community, comes to the hospital, and then requires some form of definitive intervention to prevent the long-term morbidity and mortality associated with that disease. The other thing that I tell people, and when I made the decision to pursue medicine, an old physician once told me, son, there's 3 things you need to know about being a doctor. You need to be available, you need to be affable, and you need to be able. And since then, we've added affordability, and we've also added accountability. So as an individual and as a system, we have to be 24/7, right? This is not 9 to 5. It's not, well, I got a golf game, I can't do this or whatever. We need to be nice about it. We need to be supportive of people who are trying their best. And if it doesn't always go right, that's not their fault necessarily. This is an opportunity to learn. And hopefully we're going to be able. We all got to this point by having a certain degree of ability. And then when I say accountability, this gets back to the importance of feedback, typically positive and in a constructive way. Even if something didn't go right, there's still an opportunity to improve the system without alienating people and without causing the system to suffer from disengagement because we're saying you did something wrong. So I think when you look at an individual as part of the team and when you look at the team and system in its toto, availability, affability, ability, affordability, yes, that would be nice. And again, accountability.
Before I let you go, I want to talk about this really cool website you guys put together. When I say you guys, I mean the American Stroke Association. And if you go to stroke.org/stroke transport plans, this is a really cool website. So, Dr. Yauch, walk us through why it exists and what's there for our EMS systems looking for guidance on this topic.
I think, despite the white paper being, I think, a really nice document, no one's going to spend the time to read it. And again, you want to make it practical. You want the contents to be practical for people. And so, like a lot of things that are developed either from guidelines or from ACLS, we often translate it into something that is more visually appealing, and also we remember things when put into these structures. So this consensus paper and others that have come out recently were kind of distilled down into this website that provides a distilled version of some of the recommendations, some of the considerations, and shows how they can be put into a system of care, starting with 911 to where they need to finally go. That was the point of having these kind of infographics like so many people now use to convey important messages.
Well, thank you. We're going to put the link in the episode description. I really recommend that you look at this website. It's really cool. It's got some fantastic resources on it, especially if your agency or system is doing any stroke education or consideration of structuring its stroke systems of care. No matter what level, if you've been doing this for 5 years, 10 years, or you're just getting geared up for stroke in your system, this is a really cool website to kind of check out and understand where you're at with your conditions.
And Jeff, I'll add, when you see the infographics and you see the various recommendations for the geographic regions of rural, suburban, and urban, you'll see specific time measures in there, time metrics of bypass or triage or whatever. And again, getting to our previous point, these are not meant to be absolute etched in stone prescriptive numbers. These are meant to be starting points and references for the discussion, considering the unique resources that your particular stroke system of care and your particular region happen to have. So if your number doesn't look exactly like what the infographic looks like, it's probably because you fine-tuned it and you refined it to be more applicable to your particular region.
That is all for the show today, everyone. Thank you for listening. And thank you to Dr. Christian Martin-Gill for coming on the show and spreading your knowledge. Your time is very appreciated, and we hope to have you back. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air, and please, whatever podcast platform you use, subscribe to our podcast and leave us a rating and a review. Thank you for listening to the EMS On Air podcast. Stay safe and have a great day.